Good evening, everyone. So today I will be discussing how to manage hypercarbia in a ventilated child. So there must have been many situations, those who work in ICU would know, that you have tried all the textbook solutions to bring down the PCO2, and instead of it coming down, it goes up. Especially when you're doing a normal lung ventilation, say when you are dealing with a child with encephalitis, a child with status epilepticus, or someone who's undergone a neurosurgical procedure or a pediatric surgical procedure where you're not expecting PCO2s to go up, but unfortunately they go up and they don't respond to your interventions. So as usual, I would be discussing management of hypercarbia, taking into account some real life scenarios. So coming to the topic, so that's the topic for today, that is managing hypercarbia in normal lung ventilation, mainly in normal lung ventilation. So traditionally, we have been taught that you can decrease the PCO2 by either increasing the tidal volume, increasing the respiratory rate, or increasing the expiratory time. So if someone asks you, tell us the one reason or one mechanism by which you're going to bring down the PCO2, your answer should be, I would try to bring it down by increasing the minute ventilation. Naturally, minute ventilation is the product of tidal volume into respiratory rate gives you the minute ventilation. But how do you decide which one to choose? Or why is it that sometimes when we do all three of them or any one of them, you don't get the result that you really want? So remember one thing about carbon dioxide, that carbon dioxide diffuses approximately 20 times faster across the alveolo-capillary membrane than oxygen. So it's highly diffusible. So the level of carbon dioxide in the blood depends upon the amount of air coming in and going out in a minute. That is exactly what minute ventilation is. It does not require a contact time because it is diffusing very rapidly. And carbon dioxide transfer is normally perfusion limited. What does that mean by that? If you are breathing well and your lung is getting well perfused, there is no reason why the CO2 should not be coming down. But if your lung is ventilated well, but the perfusion is less, even in that situation also, carbon dioxide can go up. And in situations where the lung alveolo-capillary barrier is abnormal, say in patients with ARDS or patients with severe capillary leak secondary to sepsis, dengue and all, even when you do everything right, the carbon dioxide washout may be subnormal. That is because of decreased transfer of carbon dioxide from the blood to the lungs because of abnormal alveolo-capillary barrier. Now, coming to the first child. So this is a 3 kg child who was ventilated for meningitis, but unfortunately you can see that the pH is 7.25 with the PCO2 of 54. Remember, as far as possible, try to always get a normal pH and a normal PCO2. When you are managing a child with a normal lung, you should never say that I am doing permissive hypercapnia. No, permissive hypercapnia is for conditions where the lung is abnormally bad and the only way to wash out the carbon dioxide is by increasing the pressures. Then you would say that rather than damaging the lungs by using higher pressure, I would trade off with a permissive hypercapnia. So whenever you're doing a normal lung ventilation, there is no question of telling that I'm going to do a permissive hypercapnia. So here, just by look at the graph itself, you know what is the problem. That I'm very, very sure about, because you can see the graphs are all abnormal. They are serrated, the tidal volume delivers are not normal. So this is the commonest cause of hypercarbia. That is when you have secretions in the tube, when you have water in the tubings, when there is a partial tube block, all that would be the reason for PCO2 increasing. So every time you come across such a graph, go ahead, suction, remove the water, and just patiently wait. The CO2 would definitely come down. There is no need to change your ventilator settings for this. So now coming to the next child. So this is a 2-month-old baby, 4 kilogram, floppy baby who's on ventilator and with a pressure support of 14 above PEEP and a PEEP of 6. And here again, as I said, the problem is the pH is low and the PCO2 is high. Now, what would you like to do for this particular child? Would you like to increase the tidal volume, or you like to increase the respiratory rate, or increase the expiratory time? Now let us first see whether we can increase the expiratory time. If you look here, you would realize that in this particular child, the expiration is complete. What do you mean by expiration is complete? Always look at the flow scalar to decide how is inspiration and expiration. Here you can see the upper limb is inspiration. It has touched the baseline. The lower limb is expiration. That has also touched the baseline. So inspiration and expiration are complete. And when you look at the expiratory limb, you should understand that once the expiratory limb touches the baseline, the expiratory flow ends there. That means any further increase in expiratory time is not going to cause any lung volume of air to come out. The flow has ended. It is just like holding your breath in expiration. So, in this particular child, because your expiration is already complete, you will not have a role in increasing the expiratory time to decrease the CO2. On the other hand, if our baby's expiration was incomplete, that is, the inspiration is starting even before the expiratory limb has touched the baseline, then definitely there would be a role in increasing the expiratory time to bring down the PCO2, which we commonly see in case of asthma patients. So here, as I already said, since the expiration is complete for this particular child, increasing the expiratory time will not bring down the PCO2. And what about increasing the respiratory rate? Right, increase in respiratory rate will increase the minute ventilation and decrease the PCO2. You are right. But how much respiratory rate do you want to increase to bring down the PCO2? Now, our child was on a respiratory rate of 25 per minute. So the resident immediately, on seeing the blood gas, increased the rate from 25 to 35. So the PCO2, which was initially 55 with a tidal volume of 7 ml per kg, and once the respiratory rate was increased from 25 to 35 with the aim that it will bring down the PCO2. But when the blood gas came, unfortunately, you found that the PCO2 has now increased from 55 to 60. Now, what happened? Why is it that your PCO2 has gone up after you have increased the respiratory rate and you are attaining a higher minute ventilation? Look at the graph once again. Here again, I would say, look at the flow scalar. What is abnormal in the flow scalar? If you look carefully, you would realize that when you blindly increase the respiratory rate from 25 to 35, it has resulted in reduction in inspiratory time to just 0.29 seconds. Remember, in pediatric ventilation, at least 3 time constants should be there for the air to completely reach the alveoli or fill more than 95% of it. That means at least 0.45 seconds should be there. So here the TI is only 0.29 seconds. So what is exactly happening here? Air is not completely reaching the alveoli. It is coming somewhere near the airway alveoli and going back. So unless it reaches the alveoli, comes in contact with the perfusion, how is the PCO2 going to get washed out? So here the problem was you have decreased the TI abnormally. So whenever you are increasing the respiratory rate, have a look on the inspiratory time. Is it adequate? Have a look on the expiratory time. Is it complete? That is mandatory. Now, even after, now, is there any way to really know how much to increase? So does this child require 25 to 35? Is it needed? In fact, you should know that PCO2 and minute ventilation is a constant. That means you know the present minute ventilation, that is 0.7. You know the present PCO2, that is 55. So that is a constant. Your desired PCO2 is 45. You do not know what is the desired minute ventilation needed for that. So if you substitute in this formula, you would realize that the desired minute ventilation would be 0.8. So now the minute ventilation expiratory is 0.7. So all you need to do is, if you increase the minute ventilation to 0.8, you would get the desired PCO2. And for that, you can multiply by the tidal volume to find out the exact respiratory rate. So all this baby needed was increasing the respiratory rate from 25 to 28. You would have achieved what you wanted to achieve. And that would have also ensured that your TI wouldn't have come down so drastically low. Now, what about tidal volume? Can I increase the tidal volume in this child to attain the this thing I want, to attain the PCO2 I want? Remember, as far as tidal volume is considered, always look at what is the delivered tidal volume. If you have already achieved your target tidal volume, then increasing the pressure support to wash out the PCO2 is definitely not an option, because that would unnecessarily lead on to ventilator associated lung injury. So look if the tidal volume is adequate. If imagine you were targeting a tidal volume of 6 ml per kg, but your settings are giving only a tidal volume of 5 ml per kg, then increasing the settings to get a tidal volume of 6 ml per kg is justified. But if you have already achieved what you wanted, then further increase in tidal volume to get PCO2 washout should not be attempted. Instead, look for alternative methods of getting the CO2 wash. But wait a minute. Just now we were telling that this is a floppy baby who is on ventilator because of poor respiratory effort. Then why is it that he's requiring a FiO2 of 60%? Why is it that he's on a PEEP of 6 and you are having a pressure support above PEEP, PC above PEEP of 14? Normally, a normal lung ventilation, you would be happy around 10, 11 should be enough for a 3-month-old baby. So what is the problem here? So always looking at the settings, you should always have that thing in mind. If I'm doing a normal lungs ventilation, that means I should be having minimum settings. If I'm requiring more than minimum setting, then there is something wrong somewhere which I have not identified. So the X-ray was repeated, and this is how the X-ray looks. So what has happened? The whole of the left side has gone into a collapse because of the migration of tube to the right side. So all you required here was pulling out the tube and giving physiotherapy, because you are basically the reason for hypercarbia in this particular child is in fact single lung ventilation. So if you pull out the ET tube, do physio, that itself will bring down the PCO2. You don't have to do all those things. There is no need to increase the respiratory rate, minute ventilation and all that. Just by this thing itself, your PCO2 would come down. So always try to find the cause and treat the cause. Every time in any clinical scenario, every time you should have that question, why? That why has to come always. So now coming to the next patient, this is not exactly a completely normal lung, I would say. It's a 4-year-old child with sepsis, septic shock on ventilator, and he's having again a PCO2 retention with a pH of 7.28. And here what you see here is that he's on respiratory rate of 30 per minute, tidal volume of 6 ml per kg, and IE ratio of 1:2. Now, here you can see, if you look at the flow scalar, here you can see that the inspiration and expiration are just complete, but it is complete. So increasing in expiratory time is not needed. So you can see the V is minute ventilation at end expiration. That is 0. That means expiration is complete. So there is no point in increasing the expiratory time. Now, should I increase the tidal volume? No. I'm happy with 6 ml per kg tidal volume because this child is grossly edematous and already requiring quite a high pressure to get that 6 ml per tidal volume. So I'm happy with 6 ml per kg. Now, what about respiratory rate? Can I increase the respiratory rate from 30 above? So now you have to understand, if I increase the respiratory rate from 30 to 35, nothing is going to happen in this child. Why do I say so? Because the patient here is already breathing at 38 per minute. You can see here the set respiratory rate is 30 and the delivered respiratory rate is 38. So remember, whenever you make an adjustment in the ventilator settings, that should get reflected in the delivered parameters, and only then there would be an outcome. So here, because the patient is already breathing at a higher rate of 38, in order for you to get a PCO2 washout by increasing the respiratory rate, you would have to increase the rate above 38. Then only it would make sense. And that is not possible in this particular child. So increasing the respiratory rate is also not an option. So then what do you do? So this is basically here the CO2 diffusion is not happening because of massive capillary leak. There, because so alveolo-capillary membrane is damaged because of the sepsis, and the interstitial edema is interfering with the CO2 washout. If you bring down the positive fluid balance, create a negative fluid balance, you will see that the CO2 comes down. In case the child is already also having a metabolic acidosis and the shock is still not corrected, then the option you have is definitely to increase the tidal volume. No other option in this particular child. Now, moving on to the next case. This is a 10-month-old, 7 kg child of post neurosurgery. So here what do you see? Baby graph looks nice. You're happy. There is no asynchrony, so there are no secretions, no tube block, nothing. Respiratory rate kept is 30 per minute. She is getting a tidal volume of close to 7 to 8 ml per kg, being a normal lung. You're okay with that. You have taken an X-ray. The X-ray is also normal. So whatever we discuss now is not there, right? Because graphs look okay, no block, and X-ray is also good. But what is it? Your pH is 7.09 with a PCO2 of 107. So why should a normal lung ventilation cause such a high PCO2? Now, so here you should know there is no problem with the ventilator. There is no problem with the lung. The X-ray is perfectly normal. The problem lies in between the two. So this, if you see here, this in fact another child, another neurosurgical patient. This is a bigger child, but what the case which I had shown is a 7-month-old baby. So you should always remember that in pediatrics, we usually connect the ET tube directly to the Y connector. But traditionally in adults, what they do is they would be connecting an elbow and then they would connect an HME and then go for an ET tube. Remember, this creates a huge dead space for an infant. For a bigger child may tolerate, but definitely for a smaller child, this is a huge dead space. That's the single reason to cause PCO2 so high in the patient. You should also know that do not use adult HME filters for children. If you want to use an HME filter, it has to be appropriate for the weight band. As you can see here, the dead space of a neonatal HME filter is just 2 ml, whereas a standard adult HME filter, it would be 90 ml. Imagine it is more than the desired tidal volume of a say 3 or 4-year-old child. It is so high. So it is important that if you're using an HME, it has to be weight appropriate. As far as possible, use heated humidifiers. And whenever you are using an HME, even in a bigger child, if you find that the ventilation is suboptimal, that means your PCO2 is not in the range that you want it to be, always go ahead, remove the HME and connect him to a heated humidifier. And sometimes because you're always emphasizing that humidification is needed, it's mandatory, come across situations where patients have started on heated humidifier. On top of that, you have kept an HME filter here at the patient end. Please do not do that. It is either HME or heated. You cannot combine the two, because what happens if you keep both? A heated humidifier will humidify the oxygen, air oxygen mixture, and you would have seen there's always some amount of raining happening there because it is highly humid, and whole of this water is going to get entrapped in the HME and it will create far greater dead space. As you can see here, right? You can literally see the water inside the HME filter. So that is something that you need to remember. Now, so I hope that is clear now. So always look at the interval between the ET tube and the Y connector. All that is a dead space. And in pediatric ventilation, that is a very, very important factor. Now coming to the next child. So this is another post-surgical patient, 5-year-old on a volume control ventilation. Here now what is happening? You can see here, he was on a rate of 25 per minute at a rate of 120 ml. Volume control mode. He was getting 120 ml at 25 per minute. So now what happened? When the blood gas came, the PCO2 was high. So immediately what was done? As we already said, increase the respiratory rate from 25 to 32 and also increase the tidal volume from 120 to 180. Now what happened? When you check the PCO2, in fact, it has gone further up. Initially, it was around 60 and now it has gone to 70. So what exactly happened? You have increased the respiratory rate, you have increased the tidal volume, and still why is the PCO2, why PCO2 has gone up? The answer lies in the X-ray. You can see the X-ray, it is showing gross hyperinflation. So what really happened here? When you increase the tidal volume, there happened a hyperinflation. On top of that, you increase the respiratory rate, because of it, the expiration became incomplete, leading on to air trapping. So whenever there is hyperinflation, the blood flow to the lung is compromised. When blood flow to the lung is compromised, carbon dioxide cannot diffuse out. So all we did was, in fact, decrease the PEEP, decrease the PIP, decrease the respiratory rate, ensure complete expiration, and the PCO2 came down beautifully to 40 within the next 2 hours. So it is important. And also this patient had an HME that was also removed. So it's very important for us to understand this particular point, that hyperinflation, incomplete expiration, increase in dead space with addition of HME will cause increase in PCO2. So what did we learn? Do not blindly increase tidal volume and respiratory rate. Always avoid hyperinflation. Whenever you are increasing the respiratory rate, initially we said ensure that inspiration is complete. Similarly, ensure that expiration is also complete. We cannot blindly increase respiratory rate. This is another patient, same scenario. You can see here what has happened here. Here, the PEEP is high and the pressure support above PEEP is also kept at 20, because of which the compliance is very low and almost there is a beaking happening there. And X-ray is showing hyperinflation. This was in fact a medical patient. And here, what did we do to bring down the PCO2? We decreased the PEEP, we decreased the PIP, and you can see and the respiratory rate also could be decreased. And how beautifully the compliance is improved. When the compliance is improving, what does that mean? The lung is inflating and deflating optimally, the blood flow is optimal, the CO2 washout is optimal. In fact, if you look at this particular flow scalar, you can bring down the pressures further down, because the compliance is so beautiful that you can afford to increase the inspiratory time further, bring down the PIP further, decrease the damage to the lung, and favor PCO2 washout. So what did we learn today regarding decreasing PCO2? We said first that you can decrease PCO2 by increasing the tidal volume only if the tidal volume delivered is less than what you want. And most common cause of a low tidal volume is not the pressure kept for pressure support above PEEP or the PIP, but it is often because of secretions and tube block. So anytime you come across a high PCO2, immediately go and see whether you have taken care of secretions, you have taken care of a tube block, you have taken care of a water in the tubing. The second is, yes, PCO2 can bring down CO2. By increasing the respiratory rate, CO2 can come down, but you have to always see that minute ventilation is good, but inspiration and expiration should be complete. Blindly increasing the respiratory rate, compromising the inspiratory time or compromising the expiratory time, both will cause PCO2 retention. And third is, increase in expiratory time will bring down the PCO2 only in patients on whom expiration is complete. If expiration is already complete, further increase in expiratory time is not going to bring down the PCO2. And last but not the least, always look for dead space. If there is anything there in between the patient and the ET tube and the ET ventilator tubings and the ET tube, try to remove it. It may be an HME filter, it may be a nebulizer. You have to decrease the dead space. Always use age appropriate HME filter. Remember, hyperinflation and extravascular lung water, both are causes of PCO2 retention. So if that is present, that needs to be brought down. And similarly, one more thing, that is in cases of in ventilated child, these are the 4 things that you really need to remember. In a non-ventilated child, in chronic hypoventilation patients, there the PCO2 may go up if you give too much of oxygen, because that takes away their drive to breathe. In a chronic hypoventilation, it is mainly the hypoxia that drives the breathing. The CO2 does not drive the breathing there. So there you have to always target a saturation around 95, but that is not regarding ventilated patients, because ventilated, you are controlling the drive. So in ventilated patients, these 4 things need to be always kept in mind. Thank you. I hope this made you understand the common fallacies that we do when we are managing patients with hypercarbia. So always ask yourself why my patient is hypercarbic and try to find out the cause and treat accordingly. Thank you.